Member Kapoor?
Present.
Member Lakin?
Present.
Member McKenney?
Present.
Membre Pinel? Vice-Présidente Poirier?
Présente.
Chair Kadri?
Present.
Member Kakish?
Present.
Member Taylor?
Here.
Member Tilley?
Present.
You have quorum, Mr. Chair.
Thank you very much. And as was pointed out, Member Pinnell has provided her regrets for this evening. Declaration of pecuniary interest, including those originally arising from prior meetings. Any declarations? Seeing none. Confirmation of minutes of the meeting of April the 3rd. Can we confirm and receive those minutes? Confirmed. Thank you. 23 communication items were received and have been received and are held with the Ms. Blais' office. Can we receive those 23 items of communication? Thank you. Motion to introduce reports. Member Kapoor, please.
Thank you, Chair. I move, be it resolved that the Chair of the Board of Health verbal report, Medical Officer of Health further verbal report, public health support for actions that promote reconciliation and advance Indigenous health equity update, update on Ottawa Public Health's immunization strategy, update on Ottawa Public Health's plan to foster mental health in our community, legalization of cannabis, a public health approach to minimize harms of use, harm reduction and overdose prevention overview and update, and 2017 operating budget Q1 Board of Health for the City of Ottawa Health Unit Status Report be received and considered, and be it further resolved that the rules of procedure be suspended to consider the following additional item due to the timelines associated with same. Report from the Medical Officer of Health entitled Appointment of an Associate Medical Officer of Health in camera, personal matters about an identifiable individual, reporting out date upon council approval.
Thank you very much. Is that item carried? The motion carried? Carried. Thank you. Item number 1. We have a verbal update from myself, so we'll hold that item. Item 2, our Medical Officer of Health, Israel, has a verbal report also, so we will hold that item. Item number 3, public health support for action that promote reconciliation and advance Indigenous health equity update. Anybody have any questions or comments on that? If not, can we receive the report?
I do have a comment and maybe even a direction. So I think the initiative is very good. My comment was specifically knowing that one of our board members has extended expertise in shelter and housing and addictions and the ranges of services there. And we've come across information recently that one of our shelters does have an Inuit population that is now becoming chronically homeless within the shelter. And I wonder if we could tie in the discussion around health equity to that relationship, because the group that wants to be struck, and I'm sorry I'll have to pull my notes here if you give me a second. The Ottawa Indigenous Health Strategy, in my mind, should also encompass emerging issues as well as ongoing ones. And I wonder if the committee would, because they're bringing all the players together, especially from the Inuit community, bring those discussions. I know that not specifically to Peter, but other of his colleagues are looking at strategies with the Wabano, with others that would be helpful. But I wonder if the range of discussions could extend to our emergency shelters.
I think that would be a good idea to include in the plan. I'll just turn the floor over to Dr. Levy if he has any comments on that.
Thank you, Chair. I could not have said it better. I think as we move forward on working with our Indigenous partners and developing a strategy, we've been doing this in a slow, deliberate way. We want to be quite sure that we have trust built into the discussions, that we're in these discussions for the long term and that they're respectful discussions, but we want to be sure that we're really getting to root cause of the health inequities that we're seeing in the epidemiology, and housing is certainly one of those. It's very clearly identified. Dr. Etches and Andrew Hendricks and Kim, who has just stepped out, are all acutely sensitive to that and are working with the partners on that. So I could have kept this really short and said thank you, but I wanted to reiterate how seriously we take that direction. Thank you.
Thank you very much, Dr. Levy. Now, based on that recommendation, can we receive this report? Receive? Thank you, Member Fleury. Item number 4, update on Ottawa Public Health Immunization Strategy. And the report recommendation is that number 1, receive for information an update on implementation of Ottawa Public Health Immunization Program, a multi-phased immunization strategy. And 2, approve that the Chair of Board of Health write a letter to the Ministry of Health and Long-Term Care recommending that social determinants of health data be collected and analyzed in the Panorama database. Question? Okay, do you want to hold it or just a quick question? Hold it. Thank you. Item number 5, update on Ottawa Public Health's plan to foster mental health in our community. And the recommendation of the report are that it's a report for information. Do we have any questions or comments on that report? Not, can we receive the report? Thank you. Item number 6, legalization of cannabis, a public health approach to minimize harms of use. And the recommendation here are 1, receive for
Question on the mental health. I believe you just passed it here. Sorry,
Okay.
I was distracted.
Do you have a quick question, or do you
It's
want
a
to?
it's a very quick one.
Okay, with the understanding of the committee, can we ask Member Fleury to go ahead and ask the question?
My question is specifically for Dr. Levy or any team member, but it relates to the idea of rating our collective mental health. I read that as part of one of the recommendations, and I question the value of that, because we know when we do a survey, it gives us a sample, and the sample only gives us one element. So I don't know if you could speak to the goals of collective mental health rating. And maybe I'm understanding it wrong, but it feels like we want to have, are we a happy community kind of sense, and what are the core issues? I wonder what the idea is behind that.
Thank you, Chair. I'm sorry, if I've interpreted the question correctly, my answer would be that self-rated mental health score is actually an excellent predictor of mental health. So when one's doing a population health assessment, and one wants to get an assessment of how a community is doing from the point of view of resiliency at a community level, the percentage of the community that self-rate their mental health as good, very good or excellent, does actually give us an indication of whether or not we have a community that is resilient to challenge. So our epidemiologists or Gillian Connolly can tell us more about actually how the study is planned to be designed. But in terms of an indicator, if that's the question at hand, the indicator actually is a proven and tested indicator that is valuable.
Thank you very much, Israel. So can we carry the report then? Received, sir. Item number 6, legalization of cannabis, a public health approach to minimize harms of use. And there's two recommendations for that. 1 is receive for information an overview of Bill C-45 and C-46 as described in this report and detailed in document 1. And number 2, approve that the Board of Health make recommendations to the federal government with respect to regulating and restricting access to edible cannabis product within the current legalization timeframe as described in this report, and strengthening restrictions on packaging and labeling to require THC contents and dose per serving size, health warnings, and plain package of cannabis product as described in this report. Thank you. We will hold it because we do also have a public delegation, so thank you. Item number 7, harm reduction and overdose prevention overview and update. The recommendation of this is that the Board of Health for the City of Ottawa unit receive this report for information.
Hold.
Hold. Thank you. Operating budgets Q1, Board of Health for the City of Ottawa Health Unit Status Report. The recommendation here for the report is that the Board of Health for the City of Ottawa Health Unit receive this report for information. We do have a technical amendment on this, so pass the floor over to Dr. Kapoor for that.
Thank you, Chair. Whereas staff has detected an error in Document 1, Ottawa Public Health 2017 First Quarter Operating Status Report, whereby the line item in reference to clean needle distribution indicates a year-to-date spent of 100%, whereas it should indicate 3%. Therefore, be it resolved that Document 1 be replaced with the attached revised version.
Thank you very much, and that's added to the report. Any questions on the report? If not, can we receive the amended report? Received? Thank you. And then we're moving back to item number 2, the first held item on this agenda. So it's medical officer, my verbal report first, and then we'll go to the medical officer health report. Good evening. Thank you very much for joining us this evening, everybody. Tonight, I would like to begin by highlighting some recent work happenings at the Ottawa Public Health. May was a busy month for OPH, starting with a significant mental health initiative. On May 4th, 2017, Ottawa Public Health, in partnership with Bell Let's Talk, launched the new Have That Talk video series and activity guide. These evidence-based videos were developed with 15 local and national partners in the mental health field, as well as individuals with lived experience. They offer tangible information on how to talk about your mental health, reducing stigma, building resilience, caring for yourself, the caregiver, and building social connections. An activity guide was also developed to accompany these new videos. We understand that this activity guide will be used in all 4 school boards in Ottawa to support positive mental health, to build resilience and coping skills, and to reduce stigma. To date, the videos in this campaign have been viewed over 400,000 times by people from all around the world. Earlier this month, I might add that they were profiled in Globe and Mail. May also saw us celebrating Nursing Week. The theme of this year's National Nursing Week was Yes, This is Nursing. The theme spoke to expanding traditional and non-traditional roles of nurses. Councillor Taylor, thank you, who shared opening remarks with OPH nurses, and I would like to echo his comments here to say thank you to all OPH nurses for your continued dedication as professionals and as advocates of health promotion, education, and disease prevention. Finally, in May, OPH launched its Secure Your Meds campaign in collaboration with Ottawa Overdose Prevention and Response Task Force. As we discussed at the last board meeting, the opioid crisis in our community is a major challenge for all of us, and we must take action. This is one of the reasons OPH launched the Secure Your Meds campaign, which encourages residents to secure medication in their household and to return unused medication to a pharmacy. We know that 13% Ottawa teens use prescription drugs that were not prescribed for them, and that 2/3 got the drug from a parent, sibling, or someone else in their household. With this in mind, I think we all have a role to play, and it can start in our homes, securing any prescription medication and returning unused or expired medication to your pharmacy. Moving to the marketing of unhealthy food and drinks. OPH launched its public consultation campaign, starting with an online survey that went live last Monday to get feedback from the community. Feedback is being received through various platforms, including, as mentioned, the online survey at haveyoursayOttawa.ca, in-person and web-based focus group sessions. Invitation to an in-person and virtual consultation were sent to stakeholders, including businesses, industry, and sports and recreational associations. This week on June 21st, OPH will be holding a Facebook Live event on our Parenting in Ottawa page with a live video stream at noon featuring the Heart and Stroke Foundation. I look forward to hearing about the results of these consultations, efforts as we look at ways to protect vulnerable populations and support all residents in healthy eating and active living. As many of you know, June is Employee Recognition Month across the City of Ottawa, including Ottawa Public Health. Several board members, including myself, members Fleury and Tilley, are celebrating Ottawa Public Health employees at various employee recognition events. On behalf of the Board of Health, I would like to sincerely thank all Ottawa Public Health employees for the work that they do every day to make all of Ottawa's communities places where people are healthy, safe, and actively engaged in their well-being. Employees have a lot to be proud of. Last Friday, several Ottawa Public Health employees were recognized by the City Manager, Steve Kanellakis. He presented the 2017 City Manager's Award of Distinction to the Rideau Street Response Team for the exceptional contribution, dedication, and exemplary service to our people in the category of collaboration and relationship building. Embodiment of the one city, one team vision. Hilda Chow, Program Manager of Chronic Disease Prevention in the Health Promotion Disease Prevention Branch, accepted the award on behalf of her OPH colleagues. I would like to congratulate employees who contributed to the Rideau infrastructure failure response, including Craig Calder, Brenda McLean, Hilda Chow, Mathieu Frappier, Michael Bennett, Carrie Chouinard, Kathy Beauregard, Shanna McMahon, Zafar Ali, Christine Taylor, Shannon Wing, Andrea Cooper, Mackenzie Turner, Denise Hébert, Tony Detre, Eric Leclerc, Dr. Robin Taylor, Kathy Downey, Siobhan Kearns, Carly Wolf, and Michael Ferguson. Several other OPH colleagues were recognized as nominees in the following categories: creative and innovation, resident and community focused. In that category, recognized people: Christine Bouchard, Kinga Sharbat, Dr. Vera Etches, Andrew Hendricks, Ashley Levasseur, Tara Mann, Kim McDermott, Pamela Oikel, Tracy Rizak, Suzanne Rowland, and Zaida Udine were recognized for their exceptional contribution to the success of 2 sexual health campaigns that offer increased sexual health services for Ottawa youth. Servant leadership. Andrew Hendricks was recognized for his ongoing commitment and significant contributions to Ottawa Public Health in the areas of employee engagement, leadership development, mentoring, and on key public health files, most recently the Opioid Prevention Task Force. Hilda Chow was also recognized for her outstanding leadership and tireless efforts in preventing chronic disease in the community. in collaboration and relationship building, embodiment of one city, one team vision. Hilda Chow, Vin Nguyen, Melissa Rotier were recognized for their collaborative work on creating a Minecraft world of City of Ottawa, which helps teach youth about healthy living using an interactive online tool to design neighborhoods. The City Manager's Award distinction is the highest distinction an employee can receive under the city's employee recognition program. Please join me this evening congratulating all these winners and recipients. Thank you very much for your work. And finally, for this evening, I also want to thank my colleagues on the board for their dedication and leadership. Our board members are consistently acting as ambassadors and champions for OPH program and services and representing OPH across the community. For instance, on June 13th, Member Taylor attended an event on behalf of the City of Ottawa and Ottawa Public Health to launch the Eat Together Ottawa campaign, which allows communities to come together to share a meal. Thank you, Member Taylor. This initiative brings awareness to our community about the impact food security and isolation can have on our overall physical and mental health. Member Pinnell has expressed interest in getting involved in our Parenting in Ottawa outreach. These are just some of the ways the board is championing OPH in connection with the community. And with that, I end my verbal report for this evening. Thank you for listening. Any comments, any questions or concerns from the committee members? If not, can we receive that report? Thank you very much. And on to Dr. Levy for his verbal report. Dr. Levy.
Thank you, Chair. Bonsoir, and good evening, everyone. I also want to begin my comments tonight by honoring the Algonquin people and acknowledging that we are meeting on traditional territory of the Algonquin Nation. And I want to extend respect to all First Nations, Inuit and Métis people and their ancestors and their elders, and to especially thank the elders who were with us tonight. It really has been an honor to have them open tonight and to have had elders with us at several of our staff events recently. Reconciliation, I think the concept of reconciliation and how each of us as individuals will embrace and move forward on bringing about reconciliation is obviously an intensely personal thing, but from an organizational point of view, we have made it a priority to do whatever we can at Ottawa Public Health with care to ensure a meaningful, sustained and long-term commitment to promote reconciliation and advance Indigenous health equity. So I very much appreciate the observations already made about the importance of being sensitive to determinants of health and being sensitive to the equity challenges that exist with Indigenous partners and people in the Indigenous communities. We're particularly committed to striving for a respectful dialogue and partnership with Indigenous partners, and will continue to support activities that enhance awareness and understanding of the historical context, the local diversity and the contemporary lived experiences of Indigenous community members. And the report in your package today provides an overview of some of those activities. As I've mentioned, we've purposefully actually not brought a report forward before because we've been wanting to advance the concept of an Indigenous partner-led initiative around an urban strategy for our community as a step towards reconciliation, and we felt that it was important that we ensure that this doesn't happen in a tokenist way. So this will be the first of the reports that come to you over what I believe will be many years as we move into what is obviously a many decades-long experience of climbing the mountain that Justice Sinclair set for us as a challenge in this country. Aside from that important acknowledgement in my own mind, I didn't want to actually speak for long tonight. I have taken seriously your comments and I think some of the jocular comments from some media members that some of my verbal updates are a little too sonorous. So we've tried to keep you updated in between meetings through frequent updates. And I know we have a fulsome agenda. So you're aware of the breadth and depth of the issues that have emerged and kept us busy since we last met. But of course, I'll take any questions about those updates that I've been sharing with you at any time, and specifically the things that have kept the organization particularly busy have been our involvement in the city's flood response, as well as the provincial activities regarding health system transformation and the ongoing consultation that the province has been involved with, or has asked us to be involved with regarding the new Ontario public health standards. So I'll be happy to answer any of those questions, of course. And also, we do actually have a report, as you know, on the opioid file. I'm happy to discuss the progress that has been made recently. There's been tremendous progress. I'm particularly proud of the work we've done on the surveillance front in this community, collecting the data in a way that is reliable and helps us make real-time decisions with a difficult, challenging set of circumstances around useful data collection that we've really worked through with a number of community partners. We've had very high levels of engagement of provincial and national mayors, and of course we've had resource commitments recently announced by the provincial government. So we'll hear about that from Andrew a little later tonight, but I can take questions now or then. Regarding health system transformation and its immediate impacts on us, I want to thank each of you again for, firstly, for putting up with the very short turnaround time on the provincial consultation material, but also for the time you've given me personally, individually, recently, as I've consulted with you. I've consulted also with community partners and with staff at OPH on organizational changes needed to best prepare ourselves to deliver on the new provincial standards and the requirements. And also, especially, I'm conceptualizing it as preparing ourselves to deliver on future public health needs in the community. And I am keeping front and center in my thinking the importance of OPH being an agile organization, able to embrace the opportunities for broader and greater impact and relevance that might come with these changes. So we really are looking to embrace the opportunities within what the province is asking us to do. I've heard from I've had over 1,700 individual comments and ideas that have come from staff in the last 4 to 6 weeks through different engagement mechanisms. More than 70% of the organization has directly provided input. So I really do feel that I've got a lot of information that's going to be helpful. And later this month, I will begin working with a revamped senior leadership team to plan a new alignment of resources, programs, and portfolios that will be ready for implementation in the fall, so that we can begin to transition our work to our new work in 2018. I've really focused on the timeline because that will help ensure that the proposed budget that we would bring forward in the fall for 2018 is going to support operational stability not only into the future but even in the balance of this fiscal year, and then we'll be able to implement the needed change and ensure compliance and ongoing excellence into the future. So it's still been quite abstract, but it's going to get fairly real for the organization as we start moving into the next phases of essentially a reorganization that prepares us for the future. That said, I want to assure you that as we're doing all of this, we're also very sensitive as we get into summer festivities in the city that there is work that will need to be done to support the city safely through the next few months. And we've got staffing plans to deal with the Canada 150 celebrations. We have again proactively worked with festival organizers to minimize harm from what I'll politely call revelry at various summer concerts. And of course, we're linked closely with the city's emergency team so we can help respond to any unforeseen events should they occur. One of the things that our epidemiology group has done, and they based this a little bit on the Pan Am experience in Toronto and on our own thinking about future anticipated needs here, is we've developed a new electronic tool, which a sample of which is on the screen. It's a dashboard. It's really an operational tool, but it's a dashboard that will help us track events, incidents, and outbreaks during the summer of 2017, should they occur. Will greatly facilitate our own work within the department. Of course, there are a lot of different branches in the organization that respond to different things: outbreaks, extreme weather, overdoses, just sporadic infectious diseases. And we want to be sure that if there are clusters of problems, that we identify them very, very quickly and that we're able to take the appropriate actions. So this tool will of course track issues of public health importance in the community, and we'll be testing it to see whether it has long-term utility as well. So that's really all I wanted to say about the substantive work of the organization. I also want to thank you on behalf of all of the staff at OPH, Chair, and all of you for your ongoing interest and participation in the various opportunities to see our frontline work, as well as for those of you that are able to participate in the Employee Appreciation celebrations this month. Councillor Kadri, Chair Kadri, has mentioned the number of employees that were honored by the city manager. It's an extremely long list. And I think it reflects the degree to which we have passionate, committed staff that are dedicated to working in partnership. I was particularly struck by the one award that we did win, which was for our participation. We had one individual win an award for our participation in the Rideau Street infrastructure emergency response activities from last year. But it struck me that whoever stands up to receive that award is literally receiving an award for the entire organization. For the flood response, I think we had about 150 of our 500 strong organization was directly involved in the flood response at some or other point in the response. And of course, when you're having as many as a third of the organization involved in these responses, we're not a first responder group. We're not resourced as a first responder group. Operationally, we're not set up as a first responder group. So whenever we go into the enhanced response, as an observation that's been made around this board table before, and we're operating as if we're a first responder group, we're essentially triggering our continuity of operations plan, and it means that the entire organization is stepping into the breach that's left as individuals move into the enhanced response piece. So I know you've acknowledged that before, but in the context of Employee Appreciation Month, falling in the same month as our Indigenous Recognition Month, I wanted to open and close my comments tonight with a specific acknowledgement of both our commitment to reconciliation and my personal gratitude to the entire employee group at OPH for everything that they do and go above and beyond, particularly in these ever-increasing numbers of enhanced responses. So, Chair, that concludes my update tonight. I promised to be brief, and I will let you judge whether I was or not, but thank you for your time and attention.
Any questions or comments on Dr. Levy's verbal report? Seeing none, Thank you very much. Oh, sorry, Dr. Kapoor, go ahead.
Thank you, Chair, and thank you, Dr. Levy, for that report. You did give us a couple of updates on items that you'd raised in previous reports. There was one item that there's been on the challenge to the bylaw on hookah smoking in restaurants and bars. I understand that we were waiting there was an appeal in the Toronto case, which I understand has since, from our last meeting, the judgments come down in favor of the city in terms of upholding the bylaw. I'm just wondering if that's affected the city's legal office in terms of how they're proceeding with our bylaw, with the challenges to our bylaw.
Thanks very much, Mr. For the question through you, Chair. The city is still in active litigation. I think that's the right term. I'll turn to our legal support, Mr. Ansari, in just a second. And in fact, we do have a date that's been set for the hearing in early 2018. I'm involved working with the legal team as we speak in terms of putting forward an affidavit and a submission to defend our position. Personally, I feel very committed to the strength of the city's position, and the city, of course, took the action based on your recommendation. I think that the decision in the Toronto situation bodes well, but I'll turn to the lawyer for an actual an informed opinion in that regard. I know that both Peel and Ottawa are still before the courts. What I can tell you is bylaw, the city's bylaw department is implementing the city's bylaws, and I'm satisfied with the partnership that we have with the bylaw department. Mr. Chair, if I may, I'll just turn to Mr. Ansari and see if he has anything to add to that.
Yeah, just to confirm, the City of Ottawa, the application to challenge the City of Ottawa bylaw that prohibits smoking of water pipes in public places and workplaces is still currently before the courts. As Dr. Levy mentioned, we do find the recent Toronto Court of Appeal decision quite reassuring. However, the City of Ottawa case is thus far generally restricted to a challenge on the basis of the Canadian Charter of Rights and Freedoms. And so that case, there may be unique legal issues on the City of Ottawa case that we're currently working through. And for the time being, it's still before the courts.
Thank you very much. Any other questions or comments on Doctor's report? If not, can we receive Israel's verbal report? Thank you. Moving on to item number 4, that the Board of Health for the City of Ottawa unit receive for information and update on implementation of Ottawa Public Health Immunization Program and multi-phase immunization strategy. So we're going to hold that report. We have a presentation. Good evening, ladies, and the presenter will be Marie-Claude Turcotte, the program manager for this item. And we do have Jillian Conley accompanying, along with Dr. Carolyn Pimp for answering any questions or any comments that they may want to add. So go ahead, please, with the presentation.
Thank you. Bonsoir, Monsieur le Président. Bonsoir, membres du Conseil. Je suis Marie-Claude Turcotte, gestionnaire de programme pour les maladies évitables par la vaccination. In June 2015, you approved the multi-phased immunization strategy. As you know, the strategy has 3 main components. And as you sign the report, we've made progress on the different phase of the strategy. I'm here tonight to provide you with an update on the work to date as well as next steps. The first phase, Every Child Every Year, was about improving surveillance of children's immunization status by reviewing the immunization records of all children attending school and childcare centers. A cleanup of the records had to be done after the transition to the provincial database Panorama. We suspected our community was well protected and that immunization rates were high based on the fact that we did not have communicable diseases outbreak. But there was a need to catch up on the documentation of the immunization and a need to comply with provincial legislation that mandate us to conduct immunization surveillance. Now that we've conducted immunization surveillance, we can rely on high documented immunization rates, as shown by our compliance report, that are close to 100%. However, work needs to continue to maintain those high compliance rates. Now that the records of students have been assessed and updated, the next step is to expand on the immunization surveillance of children who attend a licensed childcare center. By 2018, the immunization record of all children attending a licensed childcare center will be assessed, and parents will be notified of the vaccines their child needs. This is important in order to ensure that children have received all the vaccines that they need to be well protected before they start school, and also to educate parents on the need to report immunization to Ottawa Public Health. Phase 2 is about reducing inequities. The focus is the identification of subpopulations facing inequities, therefore more at risk for vaccine-preventable disease, and the implementation of interventions targeted to their specific needs. As first steps to facilitate access to immunization services for under-immunized populations, OPH opened an immunization clinic at Mary Pitt Centre. Over 3,000 clients were seen between September 2016 and now. We collaborated with the Centretown Community Health Centre to pilot a clinic for refugees living in shelters. We also continue to focus the delivery of the influenza immunization program on access to all. This is done through outreach clinics in shelters and group homes, as well as scheduling our community clinics to ensure access to all. Through the immunization surveillance process, we collected a lot of data. The next step is to analyze the data in order to identify subpopulations that may face barriers to accessing immunization. We will map the data collected through immunization surveillance to identify if there are under-immunized groups in the city. We will also explore the social determinants of health, such as language and ethnicity, as a first step to know what barriers under-immunized populations are facing. The information will be collected with clients who use our services at Mary Pitt Centre. A systematic way to collect that data would be to do it through the provincial database, Panorama, so that it can be analyzed and compared to the client's immunization record. However, Panorama does not currently have the functionality to collect and analyze additional data. Therefore, we're recommending that a functionality be added to Panorama to enable the systematic collection and analysis of such data in order to identify the common attributes of under-immunized population so that we can target our public health interventions. A lot of emphasis has been put on the promotion of immunization with children, but immunizations are received through the lifespan from 2 months and for the rest of your life. The third phase aims at promoting immunization as a core health behavior across the lifespan, including the promotion of all publicly funded vaccines for all age group. The promotion of vaccine across the lifespan will be done mostly through education and partnership with healthcare providers that are the main providers of vaccines. Thank you.
Thank you very much for your presentation. Turning to question, Dr. Kapoor.
Thank you. Thanks for the presentation. Thanks for the work. In the documents we've seen, there were two tables provided. One was on immunization coverage estimates at age 7 and 17, and the other was on compliance by students in public schools. And I want to make sure I understand the common baseline. There's a discrepancy for the TDP, the diphtheria, polio, and pertussis numbers, as well as for meningococcal vaccine, where the compliance rates are 94 to 98%, but the actual coverage, according to the Ontario surveys, in the 80s and 70s for that. So I'm trying to understand why, if compliance is high, the actual penetrance of the vaccine is so low, and why, and which number we should use as our baseline as we track how well we're continuing to do.
Thank you. Through you, Mr. Chair. So those two measure different things. So compliance measures the compliance against the Immunization of School Pupils Act. So it measures if the child actually meets all the requirement of the Immunization of School Pupils Act. The coverage measures if the child is well immunized up to their age. So they measure two different things. Also, those two data were taken at different times. The coverage rate was taken provincially, was extracted in 2016, and the compliance rates were extracted in 2017. The only tool that we have as a health unit to measure, so the second part of your question in terms of what we should use to measure, the only tool that we can use to measure is the compliance rate. It's not the best tool, but it's the only tool that we have from Panorama to see if we're actually increasing the immunization rates within our population. So there are two different measures.
If supplementary, if I could, as I remember and recall the DTP, it's at 5 and at 15, so I understand why the 17-year-olds may be different, but the compliance, but still a significant gap in 7-year-olds who, if they're compliant with ISPA, should be up to date at 7 if that vaccine's at 5, as I remember. So I'm still not sure why there's a discrepancy of that significant number, even if it is a year, 2 years apart.
Mm-hmm.
Go ahead. It is complicated in how the two things are calculated. One of the things that helped me to try and get around it is that as Mary Claude said, they are measuring different things. But an example of where a child might be compliant but not fully immunized, well, there's a couple. First of all, if they have an exemption, they are considered compliant, but they're not fully immunized. But that's a very small proportion. As you can see in the report, a very small proportion of children would have exemptions. But the other probably bigger category would be a child who is not yet overdue but is not fully immunized. So according to the Immunization of School Pupils Act, if a child is not yet overdue, they are still compliant, but it doesn't mean that they're fully immunized at that point. So coverage would say, is that child fully immunized? ISPA or compliance would say, are they overdue for anything? So I'm not sure if that helps, but that's one example of how they differ.
It helps somewhat. A slight change in subject for the next question. In terms of the parents, the new provincial act that's coming down that has, I guess, been assented to but hasn't been proclaimed, the information session that is required for parents who wish to claim an exemption. Do we have any word from the province on what that exactly is going to entail, and any word from the province on how much extra they expect to support for the extra costs that will land on our laps to ensure that happens?
Yes, so the education session will be an online education session of about 30 minutes. And parents will have to get a code. They'll have to go through the education session online, get a code, and they will have to submit that code when they submit their exemption. So our nurses will not be one-on-one presenting with those parents. They will continue to do one-on-one counseling, though, on the phone when parents ask questions about exemption.
Thank you very much. Vice President Madame Poirier.
Thank you, Mr. Chair. I just have a quick question. If I missed it, I apologize. It seems that we're becoming more adept at capturing the data about the rate of immunization and so on. I know that was a challenge beforehand. What about tracking the intended outcome, which is to have fewer people contract the disease? How are we doing on capturing that kind of information?
Thank you. We already had low incidence and prevalence of communicable disease. We are tracking, our epidemiologists are tracking all the vaccine preventable disease. There was no increase in vaccine preventable disease, but we were already low on the vaccine preventable disease.
Is that it? Thank you. Anyone else? If not, can we receive this report as presented? Received. Thank you. Sorry, we need to carry the report, not received. Carried. Thank you. Item number 6. Legalization of cannabis, a public health approach to minimize harms of use. So we held the report not only for presentation, but we also have a couple of speakers, public delegation. So what we'll do is we'll hear the presentation, and then before we go to questions from members of the committee, we will go to the public delegation for their presentation, and then we'll come back to the committee members for questions. Welcome back to the table, Jillian, and thank you for your coming in this evening, and thanks for the presentation. The floor is yours.
Merci, Mr. le Président et les membres du Council. I'd like to also introduce Jessica Brett, who's a public health nurse working in our prevention of substance misuse team, who's been instrumental in this report. So thanks, Jessica, for joining me today. I'm here today to provide a follow-up to a report that was presented to you in the fall, which provided an overview of Ottawa Public Health's submission to the Task Force on Marijuana Legalization and Regulation. Since the fall, as many of you guys are aware, the federal government has put forth proposed legislation to legalize cannabis. I'm here today to provide an overview of OPH's analysis of the proposed federal legislation. This past April, the federal government introduced the Cannabis Act, which sets out the framework for regulations for legalizing cannabis and sets areas of the federal and provincial responsibility. The federal government has indicated that the Act aims to protect youth, establish product safety, and decrease criminal activity. The proposed Cannabis Act generally aligns with Ottawa Public Health's recommendation that we put forth to the task force. The federal government has also proposed Bill C-46, which proposes amendments to the criminal code with an aim to strengthen impaired driving laws. These federal government seeks to put both these acts in force by July 2018. Ottawa Public Health has taken some time to review these proposed legislation and has identified some areas to further protect public health safety. The proposed Cannabis Act currently does not include regulations for edible cannabis products, but allows edible products to be produced at home. The federal government has indicated that regulations for edibles may come into force after the current proposed regulations. There's currently a variety of edible products that are available in the unregulated market and are growing in popularity. OPH has identified two main issues with the edible products, and this was largely based on the experience in Colorado. Firstly, there's an increase in accidental ingestion. Colorado saw an increase in accidental ingestion by children, and as well, they saw people who consumed edible products to experience as overdose. These overdoses of the edible cannabis products are not known to be fatal, but can cause severe anxiety, nausea, vomiting, low blood pressure, loss of consciousness, and psychotic episodes. These experiences were mostly due to poor packaging and labeling, improper storage, and appealing look of the edible products. In essence, people didn't have the proper information to make informed decisions about what they were consuming. OPH is recommending that the board recommend to the federal government to develop edible product regulations concurrently with the regulations proposed in the Cannabis Act. OPH is also recommending that there be investments in public education campaigns to educate the public of the harms of edible products, as well as to ensure that residents are making informed decisions of what they're ingesting. Ottawa Public Health is also recommending that the board recommend to the federal government that they strengthen packaging and labeling restrictions for all cannabis products. Products should clearly label and indicate the THC levels, as well as include health warnings. And plain packaging should prohibit all promotional features on cannabis packages, including colors, images, logos, slogans, and distinct fonts. Our next steps include participating in the federal government consultations based on the recommendations put forth to you today, as well as OPH is looking to engage with the provincial government to ensure further consideration of public health approach within the elements that are within the provincial jurisdictions. This includes prohibiting smoking of cannabis in public places, increasing the minimum age to align with the minimum age of other substances, and creating a distribution model that seeks to control availability and access of cannabis. To this effect, OPH will be participating in the Association of Municipal Ontario's Cannabis Task Force and is seeking opportunities for discussion at both the provincial and municipal level to ensure a public health approach is taken to the legalization of cannabis. That's all for my presentation. Thank you.
Thank you very much. Questions and comments from the presenter first. And like I said, we have two speakers. One is Ms. Carol McDonald. Ms. McDonald, if you're here, would you like to come to the table? Ms. McDonald is appearing before us representing Ottawa Council on Smoking for Health. Ms. McDonald, welcome, and thank you for coming in this evening to join us. You have 5 minutes to make the presentation, please. Thank you.
Thank you, Mr. Chair. I will be presenting a presentation that was put together by Carmela Graziani, Janice Forsyth, and myself on behalf of the Ottawa Council on Smoking or Health. We support the OPH's recommendations to the federal government to regulate edible cannabis products to protect children, create a public awareness campaign about the health risks of edible products, and require warnings, plain packaging, and labeling with the THC level. However, we are surprised that OPH's report did not state that 22% of Canadian youth aged 15 to 19 years smoke marijuana or provide scientific evidence about the health risks associated with exposure to secondhand marijuana smoke, or recommend that the City of Ottawa prohibit marijuana smoking everywhere that tobacco smoking is prohibited, both indoors and outdoors, or recommend a public awareness campaign about the health risks of secondhand marijuana smoke. There certainly are gaps in the provincial legislation. Bill 178 talks only about prescribed products. This regulation has not come into effect. It does not prohibit non-medical marijuana smoking. It does not ban the smoking of any other weed or substance wherever tobacco is smoked, and there are a host of new products coming on online. There's still no protection from secondhand vaping from electronic cigarettes. It was the act came in January 1st, but it hasn't been proclaimed a year and a half later. The City of Ottawa has set a standard in the past, in 2001, for indoor public places and workplaces, and outdoor spaces should read 2012. This provided momentum for the province of Ontario to enact and proclaim smoke-free legislation. But we cannot wait in the City of Ottawa for another several years for the province to act. Why wait for the legalization of marijuana in 376 days? So we're urging the City of Ottawa to strengthen the smoke-free indoor and outdoor bylaws by prohibiting the use of all other weeds and substances that can be smoked, lit, burned, heated, vaped, or combusted, including marijuana. And the advice from Dr. Richard Stanwyck is exemplary. He is creating smoke-free buffer zones around entranceways to all public places, workplaces, and transit stops in Victoria. Gaps in legislation only create confusion. To quote Dr. Stanwyck, we will be definitely moving forward on this because it's going to be causing health issues. That's the City of Victoria. Marijuana smoke contains 33 of the same carcinogens that are in tobacco smoke. The Lung Association says that the inhalation of smoke is harmful to lung health as the combustion of materials releases toxins and carcinogens. These are released regardless of source, whether it is burning wood, tobacco, or marijuana. The City of Ottawa faces an urgent need to strengthen the bylaws. Students are smoking as much marijuana as tobacco. They're using electronic cigarettes to vape opioids and marijuana. The tobacco industry is pushing new products, and the cannabis industry is ramping up production. We have a triple whammy. We're dealing with ongoing complaints about secondhand smoke and secondhand marijuana smoke in multiple unit housing, in outdoor spaces, and vaping in public places and workplaces. Dozens of other communities have adopted bylaws. The City of Victoria plans to prohibit marijuana smoking inside and outside public places and workplaces. And we've seen in the past when the City of Ottawa adopts bylaws, it enables the province to take action. We have only 376 days left, and time is running out to enact and enforce a municipal bylaw to protect Ottawa residents, workers, and vulnerable populations. Thank you.
Thank you very much, Ms. McDonald, for your presentation. Any questions or comments from committee members? Seeing none, thanks again, once again, for coming in. Our next speaker this evening is Dr. Robert Cunningham from the Canadian Cancer Society. Welcome, Mr. Cunningham. You have 5 minutes to address the committee, and thank you for joining us.
Thank you, Chair, and members of the board. My name is Rob Cunningham. I'm a lawyer and senior policy analyst with the Canadian Cancer Society. Just to speak for a few moments, first, just to endorse the recommendations you just heard from the Ottawa Council on Smoking or Health. There is this trend in terms of provincial and municipal legislation in Canada to ban smoking of anything, not just tobacco, in places where smoking is banned. So provincially, we have laws already in place in Quebec, New Brunswick, and Nova Scotia to do it. In Manitoba, there's a law that's been adopted but not yet proclaimed in force. In various municipalities, Vancouver's done so since 2009. In Ottawa, the Parks and Facilities Bylaw applies to smoking of anything. So for those places that are covered by the Parks and Facilities Bylaw, that's already done in Ottawa, at least as far as marijuana or smoking of anything is concerned. Part of the report, so first, that's the secondhand smoke, and you've heard some very good representations already with respect to that. Part of the report also deals with other aspects of cannabis, and the minimum age is still to be considered and come back before this board. Our recommendation is a minimum age of 21 for both cannabis and tobacco. And we can look to the United States for experience on this, where there's both tremendous momentum on both for age 21. So for tobacco, we have 2 states, California and Hawaii, that have a minimum age of 21 for tobacco. 240 municipalities have done so in the U.S., including New York City, Boston, Chicago, Cleveland, St. Louis, Kansas City, many others. And with respect to marijuana, all of the 8 states that have legalized marijuana in the U.S. in terms of sale have age 21 as a minimum. And in the case of D.C., where the use has been legalized but not yet the sale, there's also 21 as a minimum age there. So, right now the wording of the report has been potentially to have the same age, like 19 as for tobacco. Well, what should the age for tobacco be? And our recommendation is 21. The Institute of Medicine in the United States, now the National Academies of Medicine, reviewed the evidence and concluded that if you were to have a minimum age of 21 across the United States, you'd have a reduction over time in smoking of 12%. And among 15 to 17-year-olds, you'd have a reduction in smoking of 25%. And the thing is that if the age is 19, if you're close to the age and you're 18, you're probably going to have a sibling or a friend or somebody who's going to be able to get it. But if you're 3 or 4 years away from the age, you're much more less likely to have such a social source or such have easy access. And so the evidence is very compelling. There's tremendous momentum. The Canadian Medical Association, with respect to marijuana, prefers 25, but at a minimum recommends 21. We've had in Health Canada's consultation document for the new federal tobacco control strategy released February 22nd as a measure for consultation age 21 for tobacco. The Quebec's equivalent of a provincial medical officer of health, the National Director of Public Health, in a report just released a few weeks ago, identified age 21 for tobacco as a promising measure. So I just wanted to highlight those aspects because I know they're going to be coming back to the board and they're included in the report today. I welcome any questions that you have.
Thank you very much, Mr. Cunningham. Any questions, Dr. Kapoor?
Thank you, Mr. Cunningham. Rob, you mentioned something that I've been trying to clarify in my head for a while. And I'll ask you as well as we'll ask it to our legal staff. You mentioned that the public places, the parks bylaw
Yes.
already covers smoking of non-tobacco products, so that would include marijuana.
Correct.
As I understand it, the definition of smoking product in our public place and workplace bylaw also is that broader definition of any plant material or oils intended for inhalation. Is that, so I would have thought that applied, that there was no discrepancy between those various bylaws. Now, what I heard from you was different, so could help me understand that,
I would
please?
want to check that before giving you a full answer.
Okay, then I'll just ask staff later. Thank you. Because it is an important, the idea of discrepancies are just fertile ground for these industries to play in.
Thank you, Member Kapoor. Mr. Cunningham, did you have a response for Mr. Kapoor?
I would want to check that before giving a full answer on that.
All right, thank you. Any other comments or questions? Seeing none? Sorry. Did you want to make a comment, Mr. Ansari?
Yeah, through the chair on this matter. So there is a difference. It is correct. Under the City Parks and Facilities Bylaw, there's a broad prohibition on smoking any substance. So that would include, for example, smoking of hookahs, most notably, as well as potentially any weed or substance. So that bylaw, or that change to ban the smoking of any substance on city property, outdoor municipal property, that amendment was made on the basis of that property being city property and the city having control over activities that occur on its property. So that was the basis for that. The city bylaws in respect of smoking in public places and workplaces are separate bylaws, and those have a narrower definition that applies specifically to tobacco. So there is a difference. There is a clear distinction between the broader prohibition on smoking on outdoor municipal property under the Parks and Facilities Bylaw versus the narrower definition under the public places and workplaces as well as the workplaces bylaw. Yeah.
I was going to save it till after public presentations were done, but if I may have a supplementary for our legal staff, counsel?
Sure, or you can wait till our portion of the questions and answer after we're finished with public delegation.
I'll try to remember the details of my question.
Okay, thank you. Madame Poirier?
Actually, I think I'll wait till after the presentation is.
All right, thank you. Thank you very much, Mr. Cunningham, for coming in this evening. Okay, going forward, then you've got, I'll turn the floor back to Dr. Kapoor for his question to our legal counsel.
Thank you, Chair. If, I was wondering if the legal counsel could expand on his answer and explain to me under what provision we were able to have the bylaw on, expanded to water pipe and hookah, even for non-tobacco products, and why that couldn't be expanded, why that wouldn't also include marijuana.
Through the chair, that decision was made as a result of the Board of Health meetings in 2016 to focus on the device rather than all substances. That was in the context of the decision made back in 2016 at the Board of Health. In 2016, the Board of Health met and made the recommendation of a policy choice to ban the smoking of water pipes in public places and workplaces, regardless of substance used. And the legal authority for that was, under the Municipal Act, the health and well-being of persons in the municipality. So that was quite different than the 2012 bylaw, which was the principal purpose of the amendments back in 2012 were related just to it being city property and controlling activity on city property.
Okay. As I'm trying to, and I apologize for belaboring the point, but it's a legal technical point, and it lends itself to that happening. As I'm looking at the definition of smoking product in the workplaces and public places bylaw, as I'm trying to find it here, the version I have that I see on the city website includes other plant materials or oils. Is that not?
I don't have the bylaw. I don't have the bylaw in front of me at the moment, but that's certainly not the definition under the City of Ottawa bylaw for public places and workplaces.
I think that answers my questions, Chair. I will have some comments later on. I understand the Vice Chair has some questions as well, and do you want me to make the comments now or wait till after? I'd gladly wait till after the Vice Chair has asked her questions.
If that's what you prefer, Member Kapoor, that's the route we'll go. Member Poirier.
Thank you, Mr. Chair. My question is fairly straightforward. Mr. Cunningham spoke to the urging us to consider the 21 as the minimum age. It seems to me a few months ago we were talking about writing to the government to urge them to consider 25 because of the effect on the brain chemistry of a young person. Maybe Dr. Levy can comment on that?
Thank you very much, Chair. The age issue has bedeviled us. Like the Canadian Medical Association, the staff input to the federal task force from a consultation perspective was heavily influenced by the scientific evidence about brain function, brain maturation, and the effects of cannabinoids on the developing brain. So we agreed with and we put forward the 25 age group, age limit. As events have progressed and as the federal government put forward an age of 18 as a minimum and suggested to provinces and territories that they consider that as the minimum age but think about raising the age, as the delegation observed, where we've come to so far is to say, well, if you high levels of government are not going to use the scientific cutoff, and we acknowledge that there are other public policy reasons why decisions might be made. This is mostly around black market efforts to restrict black market impact. Then at least harmonize with tobacco, whatever that might be. Now, we're on record already as wanting tobacco, minimum age for tobacco to be increased to 21. We've established that. So by default, in fact, we would be in that space when those conversations evolve. But we haven't at this stage, got enough material to respond to from the provincial government to really put together a coherent set of recommendations to you on policy.
That's it. Thank you. Anyone else? Member Taylor?
Thanks very much, Mr. Chair. So a couple of questions, and I'll start with that one for you, Dr. Levy. I think I understand where you're coming from with respect to the age, although I think it would kind of beg the question, what harm would it do us to, in our feedback, reiterate, our recommendation for harmonization with tobacco, which we suggest to be 21? Is there a downside in us doing this?
Through you, Chair. I think we would, in a consultation process, we would do that. We have not, at this stage, done the workup sufficiently that we're putting that forward to you as a firm recommendation. We're still essentially in the monitoring stage, and the consultation dynamic is playing out through the working groups that Gillian's identified, working with the AMO group.
I guess where I'm coming from is, when I read the report, I thought, I'm on board with what you're recommending in the report, and I'm very pleased to see that we're kind of in the same place with respect to the edibles, because frankly, I think they represent a bigger challenge than the smokables. And in fact, the people who are in the marijuana community, the manufacturing community, have indicated that they consider that to be the biggest growth market, that the smoking piece will always be there, but they are really targeting the consumption of edibles as being the future. So I'm glad to see that we're saying to the feds, our feedback is develop your recommendations for edibles at the same, or your guidance for edibles at the same time. And I understand this is feedback to the federal government, but I'm struggling with if there isn't value in here in us delivering to the federal government our thoughts on how the province of Ontario should operationalize some of this. I mean,
packaging, for example, and you see that kind of recommendation. It's specifically so that 10 or 20 or 30 years from now, we don't land in a situation where advertising by stealth is happening on packaging. So we're coming at these challenges from different angles, and I think that my own view is it's a good idea. The more we inject awareness of these issues into our communications with all levels of government, the better. I think that's quite reasonable. So from a health point of view, I don't see any downside. From a policy implementation point of view, I might turn to our legal counsel just to be sure that I'm not missing something in terms of communication to the federal government around the scope of the issues that we'd expect the province would address. I wouldn't think would in any way prejudice us with the province, but I'll turn to Mr. Ansari for that.
Sorry, could I receive some clarification on the question again, please?
I'm sorry, I didn't hear that. Thank you. So Member Taylor is proposing, if I interpret it correctly, that in a communication to the federal government relating to the recommendations that we've put forward, we would also outline to the federal government what we would expect the province to be tackling from a policy perspective, perhaps including the staff perspectives on the direction that might take. So my question then is, would that in any way prejudice us with subsequent representations to the province?
I'm not seeing any impediment on the face of that, no. Right.
Could you repeat that, Dr. Ansari, in the microphone?
Sorry, I don't see any legal impediment on the face of that. Right.
So if that's the case, then you know, Dr. Levy, and I guess I'm looking at the chair, I mean, if there is an openness to it, and I don't want to, I'm conscious of not wanting to take us down in a debate that goes into a million different directions, but some of the things that the board has grappled with before, whether in relation to alcohol or tobacco or cannabis, that we have come to ground on, things like we're on record as a board saying we believe the age should be 25. Some of the things that we've, you know, heard, and I believe we're in the same space on, like, you know, we believe there should be alignment between the Smoke-Free Ontario Act and, you know, any kind of cannabis control legislation. Could we embed those in our response? And now, I mean, I'd be happy to move as such, but I don't know with timelines with respect to the report and when it's due back to the feds, how you would accomplish circulating it to board members or achieving sign-off. I mean, I'm comfortable with you. I personally am comfortable with you taking license, you know, with the direction of the board that that's what we want you to do, but that would be for other board members to decide.
Chair, thank you. I think we can take that as direction to staff, and we'll be able to work that into a letter, which will, I think, achieve the end that I understand you want to move towards.
That's fine by me then, if there's no objection from other board members.
So is that okay with the board as a direction to staff to go forward with a recommendation on the age issue on this? All right. Is that carried? Thank you. No, just, is that it, Member Taylor?
Thank you very much, Mr. Chair.
Thank you. Member Lakin.
Thank you, Mr. Chair. Perhaps this question's been addressed by Member Taylor's comments, but in the recommendations, the second one in particular spoke to marketing, not to sales and distribution, presumably because that's a provincial issue and there's no provincial agency to which to direct those recommendations. Can we expect staff to report to us on recommendations that would speak to other issues related to other issues that would in turn go to provincial agencies once they get identified?
Most definitely. I think one point of clarification, so just back to Councillor Taylor's point, the federal consultation hasn't come out. This is just our initial analysis, so there's not a report that we're needed to go back at this point to the feds. We're looking to write a letter to the federal government based on our analysis. And then so where Member Lycan, you're going is also the Cannabis Act outlines what jurisdictions is federal and what they're anticipating to be provincial, and the distribution model is one of them. And that's one of the big pieces that the Association of Municipalities of Ontario is looking at, and we're participating in those discussions. And so as we move forward in this analyzing and reviewing the legislation as it comes forward, we'll be happy to provide updates to the board when they become available.
Thank you very much. Member McKenney.
Thank you, Chair. I do want to just follow up on Member Kapoor's questioning, and especially, around the broader prohibition in public places and workplaces. I know that back in 2016, when we decided to include water pipes but not look at other plant materials, oils, that sort of thing. It was, the rationale at the time was because, we were waiting to see what was happening at the federal level and the provincial level. But today, we're a year and a half in, and we've got at least a year before legalization, and, I represent a part of the ward, a part of the city rather, where we've got shops set up and down almost every traditional main street, certainly in the downtown. So it is becoming more and more of a concern as these shops open up. And, we could be looking at, 3-4 years before provincial regulations follow. And, I guess I'm going to ask your opinion. Is it, I guess I was surprised not to see something more along the prohibition for, that expanded beyond water pipes within the public places and workplaces, similar to what we have for parks. Can you just tell me what that would, and maybe this is the question that Member Kapoor was going to ask, but can you just tell me what that would look like and why we wouldn't go forward today?
Chair, just as context, and then I'll ask Mr. Ansari to answer the legal question. My memory of the context at the time that we discussed the tobacco bylaw, when some of these issues came up, the legal opinion at the time was that there was still case law that needed to be considered in terms of the potential risk of a city bylaw actually notwithstanding legal challenge. Subsequently, and that was under our authority under the HPPA to make the necessary recommendations. Subsequently, there was interest in whether or not under the Municipal Act, and particularly the nuisance provisions of the Municipal Act, some progress could be made in that general direction. From a health point of view, the arguments stand. In all cases, the advantage of limiting people's exposure to toxic substances, whether tobacco or anything else, is desirable from a health point of view. And the objective of signaling that this shouldn't be part of our normal culture, normal behavior from a doctor's perspective or a health practitioner's perspective, if we're able to influence the environment and the culture of our community, that is where I would seek to influence. The nuisance bylaw or the nuisance rationale under the Municipal Act was deemed to be, as I recall from the legal counsel, sufficiently strong to anticipate the ability to withstand challenge. And it was on that basis that the difference emerged. With respect to where we are currently on the discussions around the substances, from our point of view, we think from a policy perspective we're on track. In terms of could we be more aggressive in terms of moving forward on some of these policy issues at different jurisdictional levels, the legal advice has been that we should be following the timelines that we are. And so I'll ask Mr. Ansari to comment further on things from that perspective.
Just by way of background first, the context today, or I should say last year in 2016, was that the provincial government had introduced amendments to the Smoke-Free Ontario Act that would allow the government to, by regulations, specify products or substances which would be, individuals would be prohibited from smoking in the same places where tobacco is smoked. That's despite, when the Board of Health met in April of 2016, there was an approval that the chair write a letter to the Minister of Health, Ontario Minister of Health and Long-Term Care, specifically requesting that the Smoke-Free Ontario Act be further amended to include the smoking of all combustible products, such that all non-tobacco substances, including water pipe product, be prohibited from public places and workplaces. So that broader approach was not taken by the province. Instead, their legislation focused on specified products and substances. So from a kind of past board decision perspective, that recommendation went out in 2016. Since that time, that legislation hasn't been declared to be enforced. It's received royal assent, hasn't been declared to enforce. The province had proposed a regulation that would have prohibited the smoking of medical marijuana. That regulation was put on hold. I can't speak about the province's intentions, but the whole legislative scheme that one might predict is that the province, after marijuana is so-called legalized, or recreational marijuana or non-medical marijuana is legalized, one might hazard a guess that the province might declare that legislation in force and specifically specify that smoking of marijuana, whether medical or non-medical, is prohibited in the same public places and workplaces. So that's kind of the indications from, or that's what the legislation might indicate might happen. There's also, under the Cannabis Act that's been tabled by the federal government, this also aligns with that approach there. There's a specific provision in the Cannabis Act that would amend the Federal Non-Smokers Health Act to prohibit the smoking of cannabis in federal workplaces. So the broader prohibition on smoking all substances, respectfully, I don't see that approach being taken at the provincial or the federal level. And as marijuana hasn't yet been legalized, or at least the non-medical use hasn't been legalized, arguably it's premature at this time, for those regulations to come into force. So, it's just summing it up. I'd say the board has already submitted a recommendation to the province indicating that the board would like to see all combustible substances, the smoking of all combustible substances, be prohibited in public places and workplaces, and that would include marijuana. So I don't know if that answers the question through the chair, but that's just kind of the background and why arguably it's, a change at the municipal level would be premature, and the board has already communicated its views to the province.
Okay, well, thank you for that. I understand it. I may not agree, but I do understand it. And just very quickly, how would non-medical marijuana then, illegal marijuana, I guess, be captured in the legislation and then eventually in our bylaws?
So currently in the city bylaws, there's no mention of marijuana. There's only two bylaws that broadly prohibit smoking of any substance. One is the Parks and Facilities Bylaw, which was amended in 2012, which affects outdoor city property, and the second would be the more recent bylaw approved by the Board of Health in respect of water pipes. So the smoking of any substance in a water pipe is prohibited. So we, in a sense, we haven't specifically addressed marijuana, but the definitions of smoking in those two bylaws would include the smoking of marijuana.
And would that include in public places and workplaces?
So the city parks and outdoor municipal property is a public place.
Right.
So in that sense, it is covered. However, again, an enclosed public place that is not city property, if you were to smoke a marijuana joint, our bylaws do not regulate that activity. And the city view thus to date is that's principally currently a criminal law issue if we want to specifically address marijuana in those places. Yeah.
Okay, thank you.
Thank you very much, Member McKinney and Member Kapoor. Before we get to you, could we read out the bylaw to hold the meeting past 7 p.m. this evening?
I won't take that personally, Chair. I move, be it resolved, that the Board of Health approve the meeting time be extended past 7 p.m. pursuant to subsection 8(1)(c) of the procedural bylaw.
Is that carried? Thank you very much, Member Kapoor.
So first, I thanked Councillor McKinney and Mr. Ansari for that exchange. It was very helpful. However, my concern still stands, is that I have grown to have very little faith in the timeliness of the appropriate senior level of government acting in time for us to avoid a loophole occurring, and that I can easily see that we're still awaiting the coming into force of acts that were passed with much fanfare and self-acclamation by the province, for example. I can easily see a situation arising where we're going to have the legalization of non-medicinal marijuana, and we are going to have no appropriate legislation once it drops from the criminal law to protect our citizens in public places, enclosed public places and workplaces. So I'm going to request that we, as the board, request that the staff look into putting in what would be required for us to put into place protections for our citizens under our purview, so that we can make sure that we don't have that legal gap. The second, that was the first point I wanted to make. I had a second point that followed on Councillor Taylor's requests regarding what was incorporated in the letter, but I'm not sure what else I need to do for that request that I just made.
I think we can take it as direction to staff.
Thank you. The second point I had was following up on Councillor Taylor's comments about how far the recommendation goes. It was what I found missing, especially as I'm hearing what the federal government's policy is in terms of issues like taxation. It worries me that with this deadline that's been placed of next summer, that a lot of the other structures that should be in place are not going to be there in terms of public education, health promotion, and a comprehensive, including the packaging, as part of a comprehensive suite of public health measures. The taxation one that we've just heard about earlier this week in the news is particularly worrisome. And it seems to me that we should be encouraging that the set of public health measures that's currently in place on tobacco be used as not just the model, but the floor for what is in place before recreational use of marijuana is legalized. And I think we could be on fairly safe ground if we also incorporated that message in our recommendations to the federal government. And I would make that request if the board would be so inclined to add that to the letter. I don't, if that's makes sense to the board and to Dr. Levy.
I think we would welcome including that kind of language in the letter, so certainly we can do that.
So is that okay, Mr. Cooper? Okay. And I don't see any objections around the table. And when we carry the report, I'll make that comment in terms of taking those three directions in consideration when accepting the report.
I thank you and the staff for their forbearance.
Thank you. Any other comments or questions from members of the committee? If not, can we carry this report with the three directions to staff that were carried this evening? Is that carried? Thank you, everybody. Moving on to item number 7, harm reduction and overdose prevention overview and update. So I'd like to welcome Andrew Hendricks, Manager for Clinical Program, and once again, Gillian Conley for Health Promotion and Disease Prevention.
So good evening, bonsoir. I'm here this evening with my colleague Jillian to update you on the latest developments on the opioids and overdose crisis, including Ottawa Public Health's response locally. At the last Board of Health meeting, I mentioned that this work continues to evolve rapidly, and I can assure you that this hasn't changed since the last time I spoke to you in April. I'd like to start by saying that the organization continues to invest a significant amount of time and resources on overdose prevention and response. And I wish to thank all of the employees across Ottawa Public Health that have been involved. This work has impacted several programs across our organization, including our school health, chronic disease and prevention of substance use, harm reduction, mental health, and epidemiology teams. And it's required a significant reallocation of staff and resources to ensure that we continue to meet the needs of our residents. Since my last update to you, we've seen a response by all levels of government in recent weeks and months. Federally, 2 significant legislative acts have moved forward, including the passing of the Good Samaritan Drug Overdose Act and significant amendments to the Controlled Drugs and Substances Act. We feel that these are noteworthy achievements and will help a variety of organizations better address some of the issues across Canada. Also at a federal level, the Federation of Canadian Municipalities Big City Mayors Opioid Task Force, including our own Mayor Jim Watson, presented a list of concrete recommendations to the Government of Canada in June, which aims to help ensure that opioid funding meets the immediate needs of cities. A list of those recommendations are highlighted in the report before you this evening, and I can say that these are welcome recommendations and they align nicely with the work that Ottawa Public Health has been doing in this area. At a provincial level, the Ministry of Health and Long-Term Care launched a new interactive opioid surveillance tool across Ontario, which I'll speak to a little bit later in my presentation. We're also pleased when last week we received notice from the Ministry of Health and Long-Term Care that additional base funding was allocated to all health units across Ontario, with a particular focus on naloxone and surveillance. The ministry has indicated that more details on the funding will be forthcoming shortly. Also, the Ministry of Health and Long-Term Care has been coordinating meetings across several Ontario cities with Ontario city mayors, and our mayor is part of those roundtable discussions as well. At a regional level, I'll update you on the work of the OD Prevention and Response Task Force. I'll sometimes call them the OD Task Force for short. But I also want to highlight that Ottawa Public Health has been actively working with the Champlain Local Health Integration Network to identify service gaps and opportunities to adjust mental health and addiction services to better assist those living with problematic substance use, as well as their parents, families, and friends. In terms of specific Ottawa Public Health contributions, we continue to be very active in a variety of different areas. The work in all of these areas continue to challenge our organization to ensure that we're meeting the needs of our residents. From a prevention perspective, our school health nurses have been extremely busy working with all 4 school boards in not only reaching students but also building capacity amongst teachers. We've been leveraging our various social media platforms to extend our messaging to residents, to parents, especially with upcoming prom nights, graduations, and festival season. A couple of meetings ago, Kira was here to do a demonstration of our Naloxone Kits and some of the training that goes with it, and I can confirm that those kits continue to be in high demand. The team that operates the peer overdose prevention program has seen almost a 400% increase in demand for Naloxone Kits. And we've already trained this year more people than we did in all of 2016. Along the lines of harm reduction, we are advancing with harm reduction dispensing units in 5 pilot sites across the City of Ottawa, which we spoke about at our June board meeting last year. So it's important to mention that the issue of overdose and problematic substance use can't be done by one single organization. I think that the mayor mentioned last week that OPH was burning the candle at both ends, and I can tell you that it definitely feels like that sometimes, and that the work is likely not sustainable without additional funding. The good news, as I mentioned, is that we did receive a small amount of funding from the ministry, which is very welcome but doesn't address the complexity of the issue at hand. Luckily in Ottawa, we have strong partnerships with many city departments as well as community partners. Here we have multiple logos from the OD Task Force for our drug drop-off Ottawa campaign. The relationships we continue to build with the OD Task Force are noteworthy and put us in an excellent position to leverage each other's services and expertise. The focus of the task force in recent months has been expanding naloxone distribution, continuing to raise awareness through stopoverdose.ca, and we've also been reaching out to people with lived experience to get various inputs on the work moving forward. Another piece of work that the task force has been working on that I personally think has evolved really nicely is the development of an early warning system in order to be able to quickly identify any increase or change of overdose activity in a rapid fashion to ensure an effective response. We used this information in April, so on April 21st, Ottawa Public Health and the task force issued a public service announcement to advise the public that there was an increase of suspected drug overdose-related emergency room visits over a 72-hour period. Since that time, and in May, we posted our first drug overdose data report, so you have a copy on the slide here. And we've since posted a second monthly report, and these reports provide available monthly trend data on suspect drug overdose emergency room visits here in Ottawa, as well as some of the paramedic data that speaks to naloxone administration, as well as opioid responses from paramedic services. This information will continue to be updated on a monthly basis. And OPH is working towards making this data available through open data as well, so that it'll be released in a more timely fashion and available to all community partners and to the public that are interested. Also on the topic of surveillance, I mentioned that the Public Health Ontario and the Ministry of Health launched a new interactive opioid tracker. That happened in May. And it's available to the public, and it has opioid-related data specific to morbidity and mortality data that goes back over 10 years. And so the data presented on this provincial website shows the rate of emergency room visits for opioid over time, and you can also compare across cities and other health units. And what we can see is that in Ottawa, and when we compare it to other urban health units, that we have a slightly lower average than the rest of Ontario combined. The data does confirm, however, that people of all ages are experiencing overdoses right across Ontario. So between these two surveillance tools, they kind of complement each other very nicely. We have one early warning system that gives us timely and useful data for early and appropriate response. And we have the Ministry of Health tool that allows us to look at trend data over time, and it's the best available data from the province in terms of quality data. So as you can see, this work continues to rapidly evolve, and it's multifaceted and will require continued investment from our organization. We'll continue to work with community partners and the task force to broaden our reach of services to parents, young adults, Ottawa residents, and all residents at risk of overdoses. This work includes some of the work I mentioned in terms of working with the Champlain LHIN to identify service gaps and opportunities. Additionally, we're going to continue to seek and inform healthy public policies that address the root causes of opioid crisis, such as the ongoing need for affordable housing and several poverty reduction strategies. Lastly, given the ongoing work, I'm committed to provide ongoing updates to the Board of Health as needed. This concludes our update. I'm happy for Jillian and myself to take questions.
Thank you very much, Andrew, for your presentation. And before we go to questions from committee, I just want to add my comments to the work Andrew and his team has been doing behind the scene, along with Jillian Conley on this particular item. And I just want to add the thanks from the board for doing that excellent work behind the scenes. So thank you. Any comments or question? Yes, Member Kakish.
Thank you, Chair, and thanks to staff for all the work that they've done on this file. I just have a question in terms of, we've allocated a lot of city resources, not just through OPH, but with fire and other departments as well. And you mentioned all the partners. And one of the things that we see, obviously, is different drugs are popular at different times. And I know you don't have a crystal ball, but how long do you foresee the opioids being the drug of choice? And what are we doing in terms of forecasting or seeing trends in the future, and how we've learned from this experience in terms of a lot of the things that we've done now obviously have been sort of reactive, but we sort of saw a trend in the emergency rooms with some of the increased visits that were pertaining to the overdoses. So just in terms of the future, what we've learned, how long we see this being the drug of choice, and what the next drug is, and how we get ahead of that from a public policy perspective, and what we can do to ensure that.
Thank you for that question. So you're correct in saying that I don't have a crystal ball in terms of predicting that. I do think that we are in this for the long haul in terms of responding to opioids and overdoses in our community. I don't anticipate that we see significant improvement in terms of the number of people that are overdosing anytime soon. We've seen, if you just look at trend data, for example, I spoke to some of the Ministry of Health surveillance tools. We've seen an ongoing trend in emergency room visits, as well as mortality data, so deaths for the last 10 years. And that number continues to go up, and I fully expect that number is going to continue to go up. In terms of specific drugs, I tend to default to the notion that people are drug users, so they will tend to shift their drug use to what's available on the market. We hear that from our clients. And so we're probably going to continue to see that. So it really depends on what's available in the community. Right now, what's available in the community would be fentanyl, would be opioid, a lot of those opioids. And what's happening in our community now is that a lot of these drugs are being laced with fentanyl, which is why we're seeing an increase in overdoses and potentially fatal overdoses. So I'll probably ask Jillian to say, she probably wants to say a couple things about alcohol, because that is the substance, and Israel would want to say a couple things about alcohol as well, because we know if we compare morbidity data in terms of emergency room visits and that, alcohol remains the most used substance in our community, and it will probably continue to be that way for many, many years to come. But specific to opioids and to illicit drugs, I don't anticipate any change anytime soon. Do you want to add something to that, or?
No, I think what Andrew was saying is bang on. It's just when you're saying it's the drug of choice, we see a lot of drugs, but if you're talking about the harms, the overdoses, as Andrew said, we're in it for the long haul as a result of the lacing. So it's not. We do look at drugs as an overall piece and what are the issues, and I think our focus on substances has been enhanced from tobacco, alcohol, and cannabis. Right now, we've had a number of those reports over the last month, last year on this, and I think what we're seeing is also, if I could say, is like a more open discourse. Like Andrew's work, he's been doing this work for a long time, and now we're having more public community discourse about how we're addressing this and what does it look like. So.
And since the tragic incidents that have happened and the drug busts and the communications and the awareness campaigns that we've been doing, has there been any changes in terms of the hospital numbers that we're seeing in terms of ODs, or just the data that you get that I know sometimes is not public or sometimes isn't verified yet, but we kind of know it is related to that? Have the numbers sort of flattened out, or are they down, or are they up?
So the short answer would be that we haven't seen a change in terms of the number of people who are seeking emergency room services, we're actually seeing a slight increase since the beginning of the year. So that information is publicly available. That's the monthly report that I was referring to in terms of people accessing emergency room visits. And so it's a really, it's a really interesting phenomenon in terms of, alerting the public in terms of the risks associated to overdoses, but also, when I spoke to that alert that we issued in April, we still saw a fairly high number of emergency room visits after the alert, and so it's really it's a balancing act in terms of how much we alert the public, and there's advantages to disadvantages to alerting the public on a frequently basis when it comes to those types of things. What Jillian was speaking to is really seeking the opportunity to engage the community and engage the public when it comes to the risk associated to opioids and to drug use in general.
Mm-hmm. That's certainly interesting and surprising to me as well, given everything that sort of happened in our city and across the province as well with this. Do you have any thoughts about if there's anything more or anything differently that we could or should be doing?
Thank you very much. Sadly, it isn't that surprising to us. We know, even though some of the tragedies in February garnered significant media attention, public interest, particularly in the suburbs, we know that the baseline rate of use in the community hasn't really changed. So what we do see, and we're looking at it every single day now, is roughly speaking, on average, somewhere between 2 and 4 people show up in an emergency room in the city, sometimes 5. Almost never as few as 1 or 0, with a suspected overdose every day. And if memory serves, in the last 3 months, we've seen that's what we call a spike, is when we see somewhere between 8, 10, 11 show up in the emergency room. Now, the good news is they're showing up in the emergency room because obviously a person who's dead on scene doesn't show up in an emergency room. That's partly why the data, we need to collect the data from so many different sources. But if you use that baseline of 2 to 4 every day, and then the spikes of 10, 11, thereabouts, happening on average maybe about once a month, we think that that's because of a bad supply coming in, and that's why we work with our colleagues in law enforcement, just to be sure that we're sharing the appropriate information without putting, obviously, our clients in a position where we lose trust in working with our clients. And so I think, Andrew's described it as an interesting phenomenon, but we think we're preventing a worse scenario. So our estimate is that we've probably averted about a minimum of 100 overdoses through our own peer overdose, the POP program, the peer overdose prevention program. On average, probably 2 a month since we initiated that. Those would have been people who had died. Since it's a bit early to be able to evaluate, but we've in the last 3 months in this community with partners, we've exponentially expanded the naloxone availability in the community. And so it's hard to prove the unknown, but we could have seen a bump, arguably, well above that baseline of 2 to 4. And in fact, we've held that baseline relatively stable with a slow creeping upwards on the rates over time. So it's a bit of an obtuse answer, but I think it would be a lot worse if we hadn't been taking these actions, or at least there's reason to believe it might have been a lot worse if we hadn't been taking these actions. And we think that the partnerships and the information that we're putting to the public is in fact having an impact in holding it stable.
Okay, thank you, Chair.
Thank you very much, Member Kakish. Member Taylor.
Thanks very much, Mr. Chair, and thanks very much, Andrew, for that update. Appreciate it. Your team is working very hard, and that's very clear. Couple of things two things I just want to speak about. First is just a comment that you had made when you were talking about the value in putting out these alerts. I don't know. I think you would have to do based on what you're seeing on your dashboard and the demographics of who we're seeing turn up in our emergency rooms, but I would suggest that if they're primarily youth, that seeing the spikes, if we're seeing youth coming into our emergency rooms, maybe it doesn't trigger an alert so much as it might want to trigger an instant blitz on Snapchat and Instagram advertising, to try and get that message out, because I doubt a lot of kids who show up in the ER are watching the 6 o'clock news. I mean, maybe they are, but I would imagine that things that show up on their mobile phones are probably compelling messages that show up on their mobile phones are probably a better way of alerting, the potential user. But I leave that for you to consider. The one piece that I wanted to talk about, you talked about the partners and how, you've done a lot of work, and you mentioned festivals and fairs. It's no secret that Escapade is coming up this weekend, Canada Day next weekend. In conversation with Tony DeMonte, who's our General Manager of Emergency Protective Services, he's indicated that, there is a fair amount of awareness around the paramedic service and our first responders about what Escapade is going to look like. And, I'm not harping on I've got nothing against Escapade as a music festival itself, but generally speaking, it has historically shown a very high number of drug-related incidents. So recently there was, a news story a short while ago. I know our SEAT team have been working with OPH about training people at festivals and fairs to be, equipped. And I'm wondering if you can talk a little bit about
what have we done, and I know we have a role and paramedics have a role, what have we done to prepare for what I expect is going to be, I hope, nothing happens this weekend other than a nice music festival, but I fear that we're going to wind up, you know, with some tragedies coming out of this weekend.
Thank you, Councillor, for the question. I think it's something that we're also cognizant of, and as you've mentioned, a few of the steps that we've been taking. So we've worked alongside a local pharmacist who has done training for the Canadian Ski Patrol, who is going to be providing first aid alongside with paramedics. We've also done training to the security guards of who will be attending the festival for overdose awareness. We've also provided training to other security firms in the City of Ottawa who will be providing security at other festivals. We've worked alongside the organizer for Escapade in terms of making recommendations about how we can be making the festival a little bit more to reducing overdoses. This is something that Andrew's team actually has been instigated a number of years ago. One of the things is access to low cost or free potable water. Creating an environment where a lot of people, more eyes on the ground, are aware of what an overdose might look like. I think when you're looking at a festival, something like that, specifically security folks might be looking at someone and think that they're drunk and you would leave them. That's dangerous if someone's actually having an overdose. So we've done that training for the security folks there. We're also actually having our staff there to be reading the information. But what we've been seeking to do and been working over the last little bit with the organizers, getting that information out to the festival goers in advance of the thing. You're going to get to the event and public health staff are there and telling you, oh, you should have a plan to get home safe and whatnot. It's too late. So we've been working with the organizer to be getting the public awareness information to his festival goers through his own channels in advance of the festival. So in essence, seeking to provide some public awareness, training, and trying to create an environment that would seek to reduce overdoses at the festivals.
Okay, so thank you for that. I think, so just a quick question on the training. So he's got ski patrol and then there's security guards who've been trained. Are they just trained or are they trained in carrying naloxone kits?
The ski patrol folks will be carrying naloxone kits, and the security people, we've done them training for overdose awareness, and should they choose to individually carry naloxone, they can. But with the wealth of ski patrol that they have on site, as well as the paramedics, we're seeing that that's sufficient at this time, but wanting to make sure that they're aware of what the overdose would look like.
The other thing I'll add, and Jillian talked about paramedics, is really working with paramedics to make sure that they have the appropriate level of resources at these types of events. And the feedback we're getting from paramedics through the task force, but through our partnerships, is that it's around the medical emergency factor. So whether you overdose in the community or whether you overdose at an event, it's a medical emergency and you need to seek support as soon as possible. So if you're at an event, you wouldn't be calling 911, you would be seeking out the on-site paramedic supports. So it's working with them to make sure that they are available and they have the appropriate resources to respond.
Okay. You talked about, you know, that our staff will be on site. I'm assuming it's, you know, I know when it's festivals and fairs, there's a lot of different threads to OPH, like, you know, we provide, different program provides different messaging, but I'm assuming there might be different buckets of program at Escapade, but I'm assuming when you talk about our staff being at Escapade, it's our staff who are trained in, you know, overdose prevention, recognition, that kind of thing, right?
Yes.
It's not like, I don't know, handing out water bottles and talking about sunscreen.
Yeah, no, I think that's exactly so. As you can see, with Andrew and I both being here, our teams have both been working on this, and we have different hats within this, and that's why we said our teams, really. So both of our teams will be there, and what we're doing for all festivals is that they have that really broad scope of understanding and awareness. So We've actually trained about 200 of our own staff on naloxone awareness, administration, and train the trainer. So we're having those staff to be on site, to be providing some broad key messages, as also to have some more eyes on ground. So broad key messages about sexual assault, overdose awareness, as well as some of the other Party Smart messaging. So that's what they're going there to. They have that information, and they have from the awareness all the way down to the administration.
So last question, and this goes back to something the chair and I were talking about earlier today. You talked about, we're going to be there, we're partnering with the festival organizer in the case of Escapade and others, and that in the case of Escapade specifically, you said they're providing information, I guess, via their channels, which I'm assuming is their social media or their website or whatever, or their email outreach to their festival goers. Are they inviting us to do that, or are we paying to do that?
It's an invitation.
So they're not charging us? We're
No.
not buying web space
Oh, no, no,
on
no.
their...
No.
Okay.
No.
All right.
I think it's actually been a positive discussion with the organizer. I think that's something that Andrew set in place a number of years ago. I know this is a heightened response or awareness right now, but it's something that Andrew's team we've been working on for a number of years with the organizer.
Okay, well, that's good. That's progress then. I know in the past we've had interactions, at least, not necessarily through OPH, but other agencies or departments in the city where they've said, you're welcome to come and be at our, but you have to pay for, for a space to be there, or pay to put something on our website. So, but if we've been invited, then I think that's progress. It's great. Thank you.
Thanks. Sure, Dr. Levy.
Thank you for the opportunity just to add a comment. I don't know exactly how that one came about, but I can tell you, Councillor, that just to reiterate my pride in the team, Gillian has just identified two things that I think we at OPH tend to almost take for granted, but I think you've really listed something that is quite special. An invitation sometimes comes about because of aggressive presence, and we do try and really ingratiate ourselves into partnerships that make sense. And I think I don't know that this was particularly an example of a success in that regard, but that progress has been slow, and we're grateful to the partners in the community who might charge others that don't charge us, but we do get a lot of in-kind support from festival organizers and certainly earned media, which is invaluable to us. The other thing that you really nailed was one of the things that we've grappled with over years is the silos within the organization, and when some of our staff have specific expertise in, for example, ultraviolet radiation and how to deal, and communicate around that, and others have specific expertise in sexual health, and others in alcohol counseling or education. It does end up, for example, at summer community events where we have an opportunity to have one or two staff members, it does end up being a bit of hit and miss as to whether or not our community is well served by the individual interaction. So we have in front of us, I think, an exemplary, an example of exemplary effort by particularly Gillian and Andrew at this time, but really an effort that we've put our minds to in terms of ensuring that an OPH staff member is able to professionally provide excellent advice on any subject. And on the opioid issue, within 2 or 3 weeks, we had pretty much 50% or more of our nursing workforce trained on the issues around opioids. And I really would take the opportunity to extend credit to the leadership. Gillian and Andrew worked remarkably well in bridging that, so thanks for your indulgence.
Thank you very much, Dr. Levy. Any other comments, Member Taylor? Member Tilley, please.
Just wanted to say, first off, Andrew and the team at OPH, thank you on our behalf. I work in a sector, as some are aware, with a very vulnerable population, and I think the lead that OPH took several months ago and extended that to partners like Ottawa Inner City Health, of which Andrew is also on that board, has made the availability of Naloxone Kits and the training of the usage thereof, where, you know, 2 weeks ago to this very night, our frontline staff, not so much trained first responders, actually saved the life of somebody who had overdosed on a washroom floor by applying naloxone, waiting the 3 minutes and applying it again as they had been trained to do so, and it's happened in several other shelters as well too. So first of all, a commendation for good work, and it's life-saving work in that case where it's gotten down to our sector. I just wanted to clarify about the spike at the end of April, if there was one, Andrew. Was there indeed an overdose spike that we saw at the end of April, or were you saying that it was consistent through May, and it was just more attention was given end of April? Could you perhaps clarify that for me?
Yes, thank you, and thanks for your comment. So we did see an increase in emergency room visits over a 72-hour window. What we do, and Cameron, our epidemiologist, can speak to the nuts and bolts of it if you're interested, but what we do is we basically have averages, and we look at different thresholds in terms of how we would exceed that average or 2 standard deviations from that average. We did see an increase over a 72-hour period, and the way that evolves is, I mean, we really need to base that information or base what we're seeing just from the quantitative numbers with community partners. And so when we saw an increase on one day, we took it upon ourselves to reach out to the members of the task force to ask them what they're hearing. So we reach out to, you know, paramedics, local hospitals, police services, shelters, those types of things, to say, you know, we're seeing an increase based on emergency room visits. You know, what are you seeing? And so we need to rely on what people are seeing and hearing on the grounds as well. In that window that I'm talking about, we did hear from one of the local hospitals that they were seeing an influx of more than usual in terms of emergency room visits, as well as some of the complexity of some of the people that were coming in. So it was requiring a little bit more naloxone than usual, so they'll do IV naloxone. And so once we heard that information directly from one of the hospitals, that's when we decided to issue a public alert in terms of the increase over that 72-hour period. But it needs to be both the quantitative piece and the qualitative piece in order to make sure that we're getting accurate information. So
My one other follow-up then would be, in such a case, and Dr. Levy, you may have answered that partly about the bad fentanyl, but do you know if in such a case of a spike that it's that there's more of an influx of fentanyl in opiates that are now hitting the Ottawa market, so to speak, or do you think it would be more a case of bad fentanyl and it's consistently in the opioids, except in this case it was just probably a bad batch versus it's always there? What are your thoughts, or is that a question maybe for OPS or something, Andrew?
Yeah, so the drug testing question is a challenging one. We don't have a great way right now to get timely information on the circulating drugs that are happening in our community. So what happens when police sees drugs, they will send that to Health Canada, and they'll get some of the results back from Health Canada, but that takes some time. It takes over a month to get that information back. So what we rely in that situation is hearing from people with lived experience, hearing from clients, hearing from frontline providers who are also hearing from clients. So for that specific example, I can't say for sure what the circulating drugs were. What I hear from clients and from community partners is that most drugs right now are being cut with fentanyl. That's continuing to happen. That will continue to happen. And so we work with the assumption, and what we advise clients and partners is that you just need to assume that your drugs are cut with fentanyl if you're getting them from the drug market or those types of things, and that they don't taste differently, they don't smell differently, they don't look differently. They could look like oxys or Percocets, and they could be complete fentanyl. So there's not really a great way right now to know what's circulating other than the anecdotal information that we get from clients.
Thank you very much, Member Tilley. Member Chernyshenko.
Thank you. I guess I've got a question or two and probably a pretty blunt editorial comment at the end. Do you think we can draw a distinction between what I understand to be essentially pain drugs, the opioids, where a large number of people have developed an addiction and are therefore essentially taking whatever they can get their hands on and are prepared to take that risk, versus, for want of a better term, a recreational drug, in days of old, the ecstasy to go out and get a buzz while you're out dancing at a festival. Is there anything close to a line between those two different kinds of behaviors and drugs, or are we really talking now about a big blur where you don't have a clue what you're getting when you pop a pill in?
So I can try and answer that question, and I'll see if Cam has anything in terms of epi to address that. It's kind of blurry, so there's not really an easy way to know what you're taking or what you're getting unless you're getting it from a pharmacy or from a medical provider, so from your primary care provider. Anything that would be purchased on the black market, you can't really know what's in it, and that's a challenge. Some of it, if you go back to some of the reasons why people take opioids in the first place, a lot of that has to do with getting it prescribed either because of medical injury, for other life situations. And so in many situations, people start on opioids for management of pain. And so that happens, and then, for whatever reason, wherever life takes you, people will then maybe need to substitute with other types of drugs. So it is kind of blurry at some point in time. I'm not sure if Cam has anything in particular to add that in terms of trying to make that line less blurry, or Jillian, but yeah.
It's that blurry then. Yeah, I guess I promised or threatened an editorial comment. I find it a very strange world when people who are going out to have a good time at a music festival or at an event are prepared to take some sort of product that not only puts themselves now at a completely unknown risk, but worse, that we have hundreds of volunteers and dedicated professionals who are expected now to have to go out and attend what is meant to be a good time in order to prevent the people who are out for a good time from dying. It boggles the mind, really, when you cut through all that we have to have hundreds of ski patrol volunteers with naloxone training and our own vastly overworked staff out trying to keep alive those who are knowingly taking a risk. It just floors me. I guess that's where we are now. But I don't hesitate to say to those people who are doing that, be aware not only of what the risk you are taking, but the risk that you're giving to other people who are there to protect you and may end up being the victims. And I say that as a counselor who's got Escapade in the center of his ward this weekend. And I know the plus side might be, well, it's right downtown now and we can get to people faster. But we've come a long way from having a good time at a party. Thank you.
Thank you very much, Member Chernyshenko. Member Kapoor.
Thanks. Just quickly, I'm thankful for two things. One, that I'm not working in the emergency this weekend. That was fortuitous timing. Escapade's always I guess, highlight of our year. It's a red flag day. But I'm also thankful for the work that you and the OPH staff are doing. And I know as much extra work as we're seeing in the emergency department, we can only imagine what it would be like without the work that you and all the other members of the team are doing. So I just wanted to say thanks personally for that.
Anyone else? Seeing none, I just want to add my thanks once again to the team for doing what you've done so far and carrying the work forward. And I do want to thank the board this evening for some very passionate comments and some very good questions on the topic. So thanks, everybody. Can we receive this report? Received. Thank you. Moving on to item number, information previously distributed. Can we receive that? Received. Motion to move in camera, and there's one piece to that. There was a piece of document distributed to each board member this evening in the envelope. If you have any questions or any concerns with that information, then we can move into camera, or we can carry that information forward without going to camera. So I'm at the mercy of the board, whichever direction you would like to go. Direction carried? Carried? Thank you very much. Motion to adopt reports, Member Kapoor.
Thank you, Chair. I move, be it resolved that the Chair of Board of Health verbal report, Medical Officer of Health verbal report, Public Health Support for Actions that Promote Reconciliation and Advance Indigenous Health Equity update on Ottawa Public Health's immunization strategy, update on Ottawa Public Health's plan to foster mental health in our community, legalization of cannabis, a public health approach to minimize harms of use, harm reduction and overdose prevention, overview and update, 2017 operating budget Q1 Board of Health for the City of Ottawa Health Unit status report as amended, and appointment of an Associate Medical Officer of Health in camera report be received and adopted.
Is that carried? Thank you. Motions of which notices have been given previously, we have none. Requiring suspension of the rule for procedure for this evening's motions, have none. Notice of motion for consideration at subsequent meeting. Anybody have one or none? Confirmation bylaw, Member Kapoor, please.
Thanks again, Chair. I move be it resolved that the confirmation bylaw number 2017-3, a bylaw of the Board of Health for the City of Ottawa Health Unit to confirm the proceedings of the Ottawa Board of Health at its meeting of June 19, 2017 be read and passed.
Thank you very much, Member Kapoor. Is that carried? Thank you. Inquiries and answers. I think Member Poirier has an inquiry.
I do on behalf of Member McKinney. So this past weekend saw hundreds of participants at the Acorn Canada National Convention in Ottawa. Acorn Canada and Ottawa Acorn are advocating for municipalities to establish landlord licensing. While the majority of regulations for landlord licensing would likely fall under the purview of building code services and property standards, could Ottawa Public Health identify its role in ensuring landlords maintain units as to minimize health risks to residents and best practices found in other municipalities surrounding this? This would include but not be limited to the maintenance of the heating, ventilation, air circulation, plumbing systems, and the prevention and control of pests.
Thank you very much, Member Poirier, and staff will come back with a response to the inquiry at the next meeting. Before I move on to adjournment, just want to remind the members the pink sheet has to be handed back to our secretary. And having said that, could we adjourn the meeting? Meeting adjourned. Thank you very much. Thanks, everybody, for joining us this evening.